Our next speaker is Professor Meranthi Fernando from the Colombo Note Center for Liver Diseases, University of Kelaniya, who will discuss the management of acute liver failure in paracetamol toxicity with a pediatric focus. And she's a valued colleague in our department and leads the only pediatric liver transplantation service in Sri Lanka. That makes her uniquely positioned to share her insights on advanced care and outcomes in severe paracetamol toxicity. Over to you, Dr. Meranthi.
Thank you, Professor Kavinda Dayasiri, for the kind invitation to speak on management of acute liver failure, a topic which is close to my heart in paracetamol toxicity in special scenario. And good morning and good afternoon to everybody who's joining from various parts of the world. Without further ado, I would like to move on with the crust of the matter. So I have no financial disclosures or conflicts of interest. Just giving the context to the talk, it had been spoken so much with the previous talk as well. We know paracetamol is a very commonly used medication which is available most of the time in most of the countries over the counter. And it comes in various forms, tablets, suspension, droppers, and maybe suppositories. It is a medication which is often used to control fever in children, which is a scary complaint among the parents when it comes to high fever, as well as it's used as an analgesic, as we all know. However, though being a simple medication, the scariest aspect of this is, most anxious aspect of this is the liver injury. When it is given in supratherapeutic or overdosage, it does cause significant liver injury, ultimately might account for death as well. So if you look at the causes of acute liver failure worldwide, the causes in children as well as in adults, a significant proportion of acute liver failures are due to acute overdose of paracetamol or acetaminophen poisoning. So this is which is coming again about more information about acute liver failure, which has encompassed around 900 participants. And you can appreciate nearly half of the population had been having acute liver failure due to paracetamol. So that's the magnitude of the problem we are talking about. So how would a simple medication like paracetamol cause liver injury and subsequently death? So we know when somebody ingests paracetamol or the acetaminophen, there's a small amount of paracetamol would produce NAPQI, a toxic metabolite, maybe up to 5% like, which can be handled in therapeutic doses by the normal liver. It can be handled in therapeutic doses by the normal liver. So when it goes above the therapeutic doses or the liver is disordered, when the NAPQI load cannot be handled with the help of glutathione, it does cause hepatic cell injury, hepatic cellular necrosis, and finally acute liver failure and death. So that's the basic pathophysiological mechanism behind the acute liver failure caused by paracetamol overdose. The body will try to compensate with the existing glutathione stores up to a certain extent in simple words, but when it goes above the therapeutic levels, when the NAPQI levels are high, it will cause cell death. This is how the macroscopic appearance of acute liver failure, a beefy red appearance and swollen liver in comparison to a chronic liver disease which would be shrunken and nodular. And this is the histological appearance of cell death or cellular necrosis. So if you think about clinical presentations, how would a child with acute liver injury or acute liver failure due to paracetamol overdose would present with? It would be essentially the symptoms of liver injury. If you take most of the children who had paracetamol overdose, it would be mainly acute liver injury or drug-induced hepatitis, in other words. There wouldn't be acute liver failure. Only a subset would progress into acute liver failure. One might come or just present to the hospital by knowing or finding out that the child has taken a paracetamol overdose, and they might present even before symptoms. Or else sometimes the children may be brought to the hospital with the symptoms like vomiting, right-sided abdominal pain, might have jaundice after some time, drowsiness, and bleeding, and later on oliguria. Mostly in the initial period, it's very important as clinicians for us to understand the patient will be asymptomatic. But don't get reassured in the initial 24 hours, the patient looks well, patient is asymptomatic, patient is expected to deteriorate rapidly unless you take correct measures if there is proven significant paracetamol overdose. So anticipate acute liver failure, though the patient looks well within first 24 hours, which is the case most of the time. So before we go into the management of acute liver failure, I would like to remind the definition of acute liver failure. It's very important because it can go either way. Sometimes we overdiagnose, sometimes we underdiagnose. Both are not good. Sometimes we think the liver injury, liver failure is directly in alignment or it's related with the transaminases. Sometimes when the transaminases go about thousands, maybe about 5,000, about 10,000, it looks very scary. But is it truly acute liver failure? No. The surrogate mark of acute liver failure is INR or prothrombin time, which will not be corrected by vitamin K. So let's look at the definition of acute liver failure. As per the Pediatric Acute Liver Failure Study Group consensus criteria, obviously there wouldn't be any evidence of chronic liver disease, which is the case in acute paracetamol overdose anyway. With this acute liver injury, the coagulopathy will be there, which is unresponsive to vitamin K, parenteral vitamin K, where it's defined as INR more than 1.5 with clinical evidence of encephalopathy, or INR more than 2 with or without clinical encephalopathy. So what does this mean? You can diagnose acute liver failure even without encephalopathy in children. That is because diagnosing encephalopathy in children or childhood might be quite challenging because the child might be irritable due to other reasons. Child might be sleepy due to other reasons as well. So it might necessarily not be the encephalopathy. Or sometimes it's very difficult to diagnose encephalopathy. So the definition of acute liver failure is not truly dependent. If you have a INR of more than 2, which is not corrected by vitamin K, it is acute liver failure. And it's not basically dependent on the transaminases. It is INR. And mind you, your transaminases levels might even come down when there is significant hepatic necrosis. So that doesn't indicate your patient is doing well. If the INR is rising, if your transaminases are coming down, that would be more worried. So I reiterate, INR is the surrogate marker for the definition of acute liver failure in any case, and so for the paracetamol overdose-induced acute liver failure as well. Now I'm moving to the main aspect of this talk, the management of acute liver failure in paracetamol toxicity. In my thinking, I can divide it into 3 main categories. The acute management and antidote, which is the N-acetylcysteine. And also management of acute liver failure, which we would do for any acute liver failure. And then the cessation of ongoing injury. I think the first component, the previous speaker talked very well in detail how to manage the antidote and what to give, when to give, and it is quite comprehensively been discussed already. So I would be mainly focusing on the management of acute liver failure when paracetamol overdose has got escalated to this state. At the same time, I would like to highlight the cessation of ongoing injury. What do I really mean there? Especially maybe in childhood, they might come to the hospital with paracetamol overdose and mother might continue to give paracetamol maybe without knowing or maybe due to other reasons. An adolescent who really wanted to commit suicide, even after coming to the hospital, might continue to take it. We might not know. So while we manage all the other medical aspects, we have to be quite careful to avoid the further injury. There had been some instances where the adolescents specifically, they continue to take paracetamol when they have these intentions to die. So focusing on the management part of acute liver failure, before that I would like to touch on investigations as well and how would we really interpret in the liver profile. As we discussed, the main cause of mortality in paracetamol overdose is liver failure. And usually the kidney failure and cerebral edema are subsequent events. So when somebody is suspected to have taken a very high dose of paracetamol, we would definitely request a liver profile. What do I mean by liver profile and how would we interpret that? So this is basically another form of drug-induced liver injury from hepatological perspective. So it will definitely cause a hepatitis. So there will be transaminitis where ALT will be a good surrogate marker. There will be significant transaminitis. AST, ALT would be definitely raised. And if there is significant paracetamol overdose, it is expected to be, the transaminases are expected to be in thousands, not in hundreds. And ALT would be quite high. And gamma-GT alkaline phosphatase might be high up to variable degrees, not very significant in the initial stage, not very helpful in the management. And bilirubin, albumin might be affected at the later stages. The next marker, but the most important marker, is the INR, because we need to find out, does this child have acute liver failure? It's very important for us to diagnose or label, is it just the drug-induced acute liver injury which has a potential to progress into acute liver failure, or has it caused acute liver failure? So considering acute liver failure, ammonia level, though we do not have facilities bedside, blood sugar is very, very important. Bedside blood sugar test on admission as well as monitoring of the blood sugars. Venous blood gas to look at the acidosis as well as the lactate. Lactate again serves as a surrogate marker of the degree of acute liver failure. We would be very worried if the lactate is rising more than 2 in 2 consecutive samples. Renal functions, creatinine and electrolytes, and sometimes phosphate is expected to be low in acute liver failure. Blood grouping and cross-matching is important because you might anticipate bleeding. And we talked about the paracetamol level in length in the previous talk. So those are the main investigations from liver perspective we would want for this child to be understood about the acute liver injury as well as the liver failure, and also to guide us on the management. What are the principles of management and what are the strategies of management of acute liver failure? So it would be more or less same for any acute liver failure plus the antidote in paracetamol overdose. So provided we have started the other toxicology management and the antidote, this would be the rest of the management if the child is diagnosed as acute liver failure. The setting of management. All the children who fulfill criteria for acute liver failure should be managed in a liver center which has got liver transplant facilities. I truly agree with the previous speaker. The 95% of the children who come with paracetamol overdose would survive. And from that rest of the 5%, maybe again less than 1% would require liver transplant. It's not the purpose of liver transplant that child is being catered or child is being managed in a liver transplant center. It is to detect this tip of the iceberg effect, where even the one child out of 100 or maybe 1,000 would require liver transplant is given that opportunity to go for that option, that treatment option, which would be life-saving. So all the acute liver failures better to be discussed early as well as, if possible, to be managed in close association with the liver center. And if you think about a transplant, it will take some time for us to prepare for that as well, which we will discuss. So it has to be a high dependency setting with good monitoring, and there has to be good venous access. Ideally 2 wide bore cannulas, and if necessary, central venous line insertion later on. And fluids, we normally try to restrict fluids to 70 to 80% in acute liver failure. The rationale behind that is the anticipated complication of cerebral edema. When we are talking about acute liver failure, the most people worry about the bleeding. But actually, what is the cause of death in acute liver failure? Is it bleeding or something else? It is the cerebral edema. More than bleeding, it is the cerebral edema which should lead to rapid deterioration, coning, and death. So provided the blood pressure is normal and patient is not hypovolemic, we would prefer to restrict fluids to 70 to 80%. If the patient has a low blood pressure, then if fluid status is adequate, then we might go for inotropes. And your fluid of choice should be 0.9 NaCl or isotonic crystalloid with a sugar-containing solution. We might start with normal saline plus 5% dextrose, but if sugars are becoming low, you can increase the sugar concentration in your drip. The definition of acute liver failure is IV vitamin K resistant coagulopathy, but still we use vitamin K to counteract the component which would respond for the vitamin K in vivo of coagulopathy. So intravenous vitamin K is part and parcel of the management of acute liver failure. Acid prophylaxis, IV omeprazole or ranitidine can be used. What's the role for intravenous antibiotics and antifungals? If the patient is not done well, it's kind of a short-lasting recovering type of acute liver failure. Patient turns towards the recovery side very fast, it's okay. But if the patient is quite sick, drowsy, there is a place for IV antibiotics and antifungals. The reason behind that is the pathophysiology of acute liver failure. What happens in acute liver failure is there is extensive cellular death and hepatic necrosis. So that serves as a culture medium for the secondary bacteria as well as fungi. And you do a lot of interventions. Child might get aspiration with the respiratory secretion. So this is a sick child. So you would want to cover the child with intravenous antibiotics and antifungals, which can be stepped down whenever possible. It's very crucial that we maintain normoglycemia, as I spoken before, and normal electrolytes, especially the sodium in the context of anticipated cerebral edema. We can use 3% saline, and our target sodium level is 140 to 145. In view of reducing the effects of encephalopathy from the bowel flora, we would try to get good bowel opening with enema as well as with lactulose. And neuroprotective measures. Keeping the child in head-end elevated position 30 to 45 degrees, controlling fever with other measures, as well as minimizing sounds and all sorts of other things which we use to protect the brain. What is the place for blood products? We know the coagulopathy is one of the main complications and associated features of acute liver failure. So your INR might rise from 2 to 3, 3 to 4 might go up to 6. So when would you consider transfusing? If you are in a well-resourced center, you have the access for this facility called rotational thromboelastometry, which will give you a 360-degree assessment of your hemostasis, extrinsic pathway, intrinsic pathway, fibrinogen, as well as the platelet activity. So it's the best thing is to get guided with the rotor in view of your transfusions. If you are in a resource-limited setting, if there is no bleeding, you can observe up until INR 3. But if there is bleeding, you might have to correct it with fresh frozen plasma as well as cryoprecipitate due to anticipated fibrinogen deficiency. Why do we want to use a restrictive transfusion policy and we want to use why do we want to use blood products rationally? There are some implications, the plus points as well as negative points. Whatever we say as clinicians in a referral center, high-end center with a lot of resources, maybe it's quite scary for the local pediatrician or a person who works in the periphery to watch a INR of 4. That we truly understand. But if possible, if there is no bleeding, sometimes we have waited and watched with INRs of 5 without bleeding with the ROTEM guidance as well. If you unnecessarily give the blood products, it might worsen cerebral edema as well as it will mask your progressive marker of INR, which will help us to determine the timing of liver transplant. Because one of the markers we consider for the timing of the liver transplant, if the child doesn't recover, is INR. But if you have to give a FFP transfusion, fresh frozen plasma, that chance is not there. You have to go by the other markers. But on the other hand, you don't want to lose the child due to bleeding as well. It's a balanced situation. The other management strategies would include avoiding aspiration. If the child is drowsy, Glasgow Coma Scale is low, then you might have to consider nasogastric tube insertion and obviously a urine catheter. And you can use albumin infusions, diuretics, and ursodeoxycholic acid appropriately. Monitoring is crucial with the vital parameters, blood sugar, urine output, as well as Glasgow Coma Scale. The GCS is very important because that is again another surrogate marker which we would consider in terms of timing for liver transplant if the patient doesn't make a recovery. At least 8-hourly blood test with a venous blood gas. You might do it early if the patient is rapidly deteriorating. Talking to the family is very important. That is also included in the management because this is a sick child. It might go either way, might need to escalate for transplant or other methods. So it's a very crucial factor that you get in touch with the family since beginning. So having told about the principles of management of acute liver failure, what are the markers which will indicate that the liver is not being rescued? If you have worsening encephalopathy or cerebral edema, if you have worsening coagulopathy which is uncorrected, and rise in lactate may be more than 2 in multiple locations, low blood sugar and cardiovascular instability. These are some of the markers which will indicate that you are not going in the right direction. You might have to contact your transplant team and be ready with the liver transplant option. And in Sri Lanka, it's basically a living donor related program. So we need some time to get a living donor and to do the emergency workup. I know in the West, sometimes it's quite easy because they do have a good cadaveric program. And when you activate the liver transplant system, then you might end up getting a liver graft within 4 to 6 hours, which is not the case in our country right now. So moving into one more important factor about the timing of discussion with the liver center and referral to a liver transplant center, I would try to quote this guideline, which is the British Society of Paediatric Gastroenterology, Hepatology and Nutrition, which was updated to be reviewed on March 2026 and which was reviewed in 2024. So it clearly states the criteria for early discussion with the liver center. And as you can see on the screen, if there is acute liver failure, if low pH, and if there is associated acute kidney injury, which is directly related to the liver, presence of encephalopathy, any grade of encephalopathy, hypoglycemia, and signs of severe hepatic necrosis, persistently high lactate more than 2, I would say 2 consecutive readings within 6 to 8 hours apart. And some special indications like when there are cases like intravenous paracetamol overdose and paracetamol overdose in a neonate and paracetamol overdose in a previous liver transplant recipient. And patients with other liver pathologies who are known to have liver disease. So these are basically the indications that Daspagan would recommend to discuss with the liver center as early as possible. So I would like to quote this Naspagan guideline on acute liver failure and the disease trajectory to explain to you how difficult for a hepatologist or for an MDT team to time the liver transplant, especially for a case with paracetamol overdose. If you have a child with Wilson disease causing acute liver failure, it's sometimes quite easier to time for the liver transplant. You started on chelators, it's not working, and there's a less chance of recovery, you go for transplant. But as we know, paracetamol overdose is a cause where the liver would mostly recover without a transplant. So when to cross the boundary, when to list for liver transplant, it's a very tricky decision. So if you see this trajectory and if you analyze them, there would have been children who required transplant, actually would have recovered if you did not transplant them. But on the other hand, if there might have been cases you had delayed the transplant thinking they would recover because there's an antidote and it is expected to recover. But the child died because you did not escalate them timely into transplant. So it's a very hard decision. That is why we always go by set criteria as well as a multidisciplinary team approach. Because you can argue either way, what is the timing to escalate for liver transplant? You might want to avoid unnecessary transplant. At the same time, you might don't want to lose the child as well. So it's a quite tricky decision, the timing of the transplant. That is one of the reasons the child should be in a liver center for the clinicians to understand the disease trajectory rather than getting quite unstable and transferred over. So these are King's College criteria about the transplant. So they consider liver transplant option if these parameters are there. Arterial pH is low with acidosis, and if the PT is more than 100 or they give a INR value of more than 6 to consider for transplant. And if the lactate is more than 3.5 or more than 3 after fluid resuscitation. So it's always a tricky decision, and it will be MDT decision. Talking about our data, I do work in Colombo Center for Liver Diseases, which is the only specialized pediatric hepatology and transplant center for Sri Lanka. And we have seen over 1,000 referrals from 2020 to 2026, all the referrals about liver diseases and liver problems. Out of that, there had been 48 cases of acute liver failure. And it's kind of a little bit biased sample because we get primary liver failures rather than secondary liver failures. The infections and hypoxia caused liver failures would go to pediatric ICUs. The primary liver failures like autoimmune, Wilson's, drug-induced would come over to liver transplant center. So out of those 48, there had been 3 acute liver failures which ended up coming to liver transplant center here. So you can see the number of referrals had been very less because people would not think about the need for the liver transplant and the severe complications which can come on. Luckily, all 3 recovered without a transplant, but I can recall one referral which was referred quite late and child died before they stabilized the before they stabilized the transfer over to the liver center. So I can remember one death where it was escalated a bit late and child was kind of having significant cerebral edema and died without getting escalated to the liver center. So this is just to talk about the worldwide experience, and there had been cases where liver transplant option has saved many lives with the acute liver failures caused by paracetamol overdose. This is one study which is coming about acetaminophen and mushroom toxicity, where there had been 18 cases who were referred with acute liver failure, and 9 had required, and another study where the 9 had required liver transplant out of 475. So you can see there had been, in this study, there had been nearly 500 referrals, but 9 had only transplant. It's like tip of the iceberg, but those 9 lives were saved by timely transplant. So just to summarize what I've been talking so far, paracetamol overdose, the main cause of mortality is liver failure. It's basically acute liver failure. Most of the children will develop acute liver injury, but not acute liver failure. And out of the children who develop acute liver failure due to paracetamol overdose, again, a minority will require transplant. And there are the modalities which can be used to rescue the dying liver in acute liver failure, especially in the context of paracetamol overdose, which includes plasmapheresis or the CRRT, continuous renal replacement therapy, or sometimes exchange transfusion. There is conflicting evidence. There are certain cases which has resulted in positive outcomes. There are certain cases which talk about negatives about it because it might delay the need for the transplant. It might delay escalating into a transplant, and it might cause fluid overload, especially with the plasmapheresis, not with CRRT, and might worsen cerebral edema. But if you are in a well-developed center, you have bedside CRRT, it's always good to start CRRT while you prepare the patient for transplant. That option we do not have at present in our center. So what are the other options to rescue this liver? We talked about liver transplant. There's a newer modality of liver transplant called auxiliary liver transplant, which is indicated only for limited indications. So paracetamol overdose is one of the indications for auxiliary liver transplant. What do we mean by auxiliary liver transplant? You keep the child's liver part and you give new liver as well. So child will have old liver half and new liver half, and the new liver will take over the liver functions till the old liver recovers. And when the old liver recovers with the bridge of the new liver, then you might be able to take off the immunosuppression, which is otherwise lifelong, and your new liver will get kind of rejected, and your old liver or your native liver would take over your life. So it's kind of a bridging liver transplant where you get somebody else's part of the liver, having your own liver, till your liver recovers from the paracetamol overdose. The advantage of auxiliary liver transplant is you can come out of the immunosuppression at some point. So paracetamol overdose is one of the indications for auxiliary liver transplant. Hepatocyte transplantation is again something similarly. You can have your native liver which has already failed but has a potential to recover, and you might give some hepatocyte infusion as well, which will regenerate and take over the liver functions till your liver recovers. So that's all about the acute liver failure, medical management, and the liver transplant. But as we always reiterate, the majority would not require liver transplant, and this is a study which has evaluated the survivors and their long-term prognosis without a transplant who had paracetamol overdose-induced liver failure, what happened to them and their liver functions in the long term, who did not require a liver transplant. It's actually complete recovery. It is complete recovery. Liver is a marvelous organ which has a remarkable capacity to regenerate, and it's beautiful to watch how it recovers and regenerates. So it will return to 100% normal recovery. So this is actually my last slide. I just wanted to take your attention into this point, specifically about N-acetylcysteine and acute liver failure. When we manage our child also, there was a bit of a controversy about N-acetylcysteine infusion as well as the duration of it. So I went on reading the Baspagan guidelines, and this is what the Baspagan guideline says. If you see, my question to look through this guideline was actually about the duration of N-acetylcysteine infusion in view of acute liver failure. Because what I could recall when I was doing my fellowship in Birmingham Children's Hospital in the UK, in the liver center, what we used to practice at some point was we were mainly getting guided by the INR. If the INR is less than 1.3 in 2 consecutive values, we were quite confident to stop N-acetylcysteine, where the AST-ALT recovery would take some time, which is expected with the half-life being 3 days of ALT. So, and we did not observe any issues with that. So, but there were kind of conflicting thoughts whether to continue in acetylcysteine or whether to stop. Even when I looked at the guideline, I still remained a bit confused, because in 3 arms, if you see, it's kind of 3 different things. If you look at your left side of the screen, it says normal INR, PT, LFTs, ALT less than 2 times upper normal, or INR less than 1.3 and ALT falling on consecutive samples. So I would actually, practically, I would like that if INR is less than 1.3 and you see child is recovering, we know ALT would take some time. So I would consider stopping N-acetyl infusion, but I would like to discuss that in this forum, because I think we unnecessarily continue N-acetylcysteine in view of transaminases, which is expected to take some time for the recovery. It's mainly when you have INR less than 1.3, that means liver has returned to a very good state of recovery. So that slide, I would like to keep it open for the discussion in view of duration of N-acetylcysteine in acute liver failure caused by paracetamol overdose. So dear friends, I was trying to tell you the management of acute liver failure caused by paracetamol overdose, and I was trying to reiterate the clinical features as well as the investigations, how to interpret the investigations, definition, and then how to manage, and a bit about liver transplant and its place. I would like to highlight as the take-home messages, paracetamol toxicity-induced acute liver failure should be suspected and managed promptly and effectively. And discussion with the liver center early would improve outcomes. With that, I would like to thank everybody, and this is the place where we work, Colombo Center for Liver Diseases, the Specialised Hepatology Center and only Paediatric Liver Transplant Center in Sri Lanka. Thank you for listening.
Thank you very much, Professor Meranthi, Fernando, for your excellent and a very comprehensive presentation.